Okay. Yeah, Sakthivel, you can start. Can you hear me, Sakthivel?
Yes, I'm hearing.
Sakthivel, can you hear?
Yes, ma'am, I'm
Yes,
hearing.
ma'am.
Just
I'm
I'm
hearing.
putting
Just
the
I'm putting
slides.
the slides.
Okay, sure.
Good morning, Undal.
Good morning, ma'am.
I'm presenting
I'm
on behalf of
presenting
Chittur
on behalf
Mixon,
of Chittur Mixon,
Resistance in
Resistance in India.
So here, Mr. X, a 42-year-old gentleman, present as a cook by occupation with upper middle socioeconomic class, presented with complaints of fever for past 3 days, followed that cough with expectoration for past 10 days, and breathlessness for past 3 days. History of presenting illness, here presented with high-grade intermittent fever with chills with no rigor for past 3 days. Followed that he developed cough with expectoration. Initially, it was yellowish purulent sputum, which was not blood stained. Followed that he developed breathlessness for last 3 days, which initially it was MMRC grade 2, which was worsened to MMRC grade 4 at the time of presentation. He had no history of any paroxysmal nocturnal dyspnea or orthopnea, no history of any chest pain or palpitation, and no history of any recent hospital admission also. No history of any loss of weight or appetite. On past history, he was initially treated with deflazacort, which is steroid, and cefepime on the OPD basis for 2 days. But followed that also. Ma'am, am I audible, ma'am? Hello, ma'am, I am audible. So her personal history wise, he had mixed diet with occasional habits of smoking and alcohol. On examination, yeah, vitals initially had tachypneic tachycardic pulse rate of 110 with respiratory rate of 36 and blood pressure of 110/70 with saturation was 98%. He had no pallor, icterus, cyanosis, clubbing, or lymphadenopathy at presentation. He was morbidly obese with a BMI of 38 with acanthosis nigricans was present. On respiratory system examination, the trachea was in midline, bilateral equal rise of chest with right intercostal tenderness was present. And dullness was noted over in the right infrascapular and infraaxillary region, associated with decreased vocal fermentation, vocal resonance in the same right infrascapular and infraaxillary area. Other systemic examination within normal limits. So the syndrome complex we initially suspected was a patient presented with high-grade fever, cough with expectoration with breathlessness. On examination, he was tachypneic, tachycardic with systemic feature. Examination features were suggestive of right side pleural effusion. So the clinical diagnosis we arrived was community acquired pneumonia with probable pneumonic effusion. So the etiology is initially we considered was mostly bacterial. So mostly Streptococcus pneumoniae, Staphylococcus aureus, or Haemophilus influenza. Viral influenza is very less likely because of the duration of the presenting illness. So far, this we further initial investigation we sent. In the initial investigation showed elevated counts with no any multi-organ dysfunction was noted there with elevated inflammatory markers. Based on the initial patient was morbid obese with acanthosis nigricans, we sent HbA1c also because of the risk factors analyzing. It showed uncontrolled diabetes as a HbA1c of 10. With follow that he was taken to chest X-ray. In the chest X-ray, it shown as the right side pneumonic, right side mild to moderate pleural effusion was there. So initially the patient was technique was started with NIV supports. Follow that he was empirically started with piptas and azithromycin. But follow that also he was not clinically improved. Persistent tachypneic and tachycardic on NIV support also. It was planned to tap the pleural fluid. In the pleural fluid analysis, initially grossly it was a straw color fluid with pleural fluid analysis showed pH of 7 with counts of 3,312 with differential counts of neutrophil was 95% with LDH of 5,000 with blood protein of 6 and LDH was 453. So initially it was the light criteria of exudative, but other features like pH differential counts with LDH were suggestive of empyema. So we initial gram stain, the pleural fluid grossly it was not a pus, it is a straw color fluid only. So we sent for gram stain, but initially gram stain it showed moderate pulses with no bacteria. So we continue the same antibiotic course, but follow the culture. In the pleural fluid culture, it showed as a Staphylococcus aureus which was a methicillin resistance. So the final diagnosis we arrived was community acquired pneumonia with curve of 1 with PSI of 82 points class 3 with pneumonic effusion as a empyema, which was MRSA with newly diagnosed diabetes mellitus. I mainly want to talk about the community acquired pneumonia with MRSA in the community background. So all infections occurring among outpatients are among inpatients with an MRSA isolate obtained earlier than 48 hours during the hospitalization. It was called as a community acquired MRSA. The total incidence in the India, it was a 0.5 to 0.6 case per 1 lakh population. Overall, community acquired pneumonia has a high mortality, which was a 56 to 63%. Because if the virulence factors presented with the in the MRSA of community acquired origin. So most of the patients will present as a influenza-like symptoms in the 41% and had 95 the Panton Valentin leukocidin. It was a high risk virulence factor which was mostly associated with community acquired MRSA. This virulence factor mainly cause the leukocytosis with lung necrosis, mostly will causing associated with severe multilobar pneumonia or necrotizing pneumonia. And it was the most virulence factor causing the high mortality in the community acquired pneumonia if patient was not treated with adequate antibiotics. Otherwise, in the immunocompetent patients itself, there is a risk of mortality it was high. And another one gene was a staphylococcal casette chromosome. It was a MEG gene who causing the methicillin resistance in the Staphylococcus aureus. But it have multiple types, more than 9 types was there. But 1, 2, 3 was mostly associated with hospital-acquired pneumonia. But in the community origin, it was associated mainly with the type 4 and 5. The difference between was in the type 1, 2, 3 will cause all have multiple antibiotic resistance it will cause. But the type 4 and type 5, it will cause the less antibiotic resistance to the non-beta-lactam antibiotics. So it have more susceptible to other non-beta-lactam antibiotics like clindamycin, all mostly susceptible to MRSA group also, if you get the susceptible report. This is a systematic study done on 74 articles over 114 patients, was analyzed the incidence, characteristics, and outcomes of the patients with severe community acquired origin. In this, patient mostly who had shock or severe community acquired pneumonia have higher risk of mortality. But patient who presented with complaints like most commonly presented as influenza-like symptoms, fever, cough. But the patient who presented with chest pain was very, very low in this, who presented with pneumonia. So if patient doesn't present with chest pain or in the examination, we don't have find any intercostal tenderness. So we less likely we suspect as a empyema. But these patients have increased risk of developing MRSA or mortality also will high. So if patient is less likely presenting chest pain, but if have mild to moderate effusion, we need to pleural tap to confirm the no other isolated organism is there. So the patients who had complications with with acute respiratory distress syndrome or multi-organ failure had more risk of mortality. This is in this article, it showed the prognostic factors associated with the MRSA who won the community version. The mortality was high. Patient who presented with influenza like symptoms, leukopenia, shock, ARDS, multi-organ failure, or disseminated intravascular coagulation, or patient who was admitted in the ICU with mechanical ventilation. And group prognostic factors was young age, but others like secondary communicable pneumonia, pleural effusion, and chest pain. This all caused the yearly intervention of the patients. So that's what's improved the outcome. This is another one retrospective cross-sectional study. It was analyzed methicillin-resistant Staphylococcus aureus of isolates from the 15 Indian tertiary care centers. In this picture was patients who isolates were diagnosed as Staphylococcus aureus, including community-acquired or hospital-acquired pneumonia. And intervention was antibiotic susceptibility testing compared with methicillin-sensitive and methicillin-resistance. So the outcome they analyzed mainly was prevalence and resistance patterns. The time duration they done was from the 2008 to 2009. In this study, the CMC or microbiology also include as one of the centers. In this F, it showed in the 2008, we have 33% of MRSA isolates. 2009, it was 39%. The overall MRSA prevalence was increasing. So in India, the total prevalence was 41%. In the outpatients itself, it have from 27 to 28% of we have. In the ward, we have increased of 40 to 48%. In ICU settings, it also around 40% we have. In the duration, we found no any resistance to vancomycin or linezolid. In the clindamycin, the MRSA will have 50% population will have the resistance and 50% of the sensitive to the clindamycin also. This is another one, a case report. It was similar to our patient, community-acquired methicillin-resistant Staph aureus with syndemonic effusion. He was a 59-year-old gentleman with recently diagnosed diabetes. Came with similar complaints of fever, cough with right side chest pain. With initially he was tachycardic, tachypneic, required NIV support. He did initially CT. In the CT, it also showed pneumonia with syndemonic effusion. But initially, he was treated with piptas and azithro. In the pleural tap, it showed a neutrophilic predominant. So they initially suspect as a TB. So they sent for tuberculosis analysis, but all came negative. Only the last time they found out the culture shown as a MRSA. Then only they switched to vancomycin, and follow that patient was clinically improved. So coming back to our patient initially started with NIV, was initially started and stopped, follow that. Initially, first patient was started on peptas and azithro, but after the culture report, he was changed to vancomycin. He was planned for intercostal tube drainage in view of empyema, we suspect, but patient is not willing. After that vancomycin, patient was clinically improved. He was discharged. On the OPD basis, we followed up. He came, that time he was pulse rate was 88, not tachycardic, not tachypneic, afebrile, no symptoms of cough, fever, tenderness also, chest pain also. So we advise to continue the antibiotics for 14 days. After that, plan to stop. So the chest X-ray, it will at the time of admission to this is a OPD time, but it is a little bit improved, but it will take some more time on 4 to 6 weeks to clinically fully improve in the radiological. So the main learning points was the incidence and prevalence of the community-acquired pneumonia, the prognostic factors, and importance of Staphylococcal cassette chromosome, MXGene, and the PVL toxin. Thank you.
Thank you, Sakthivel. Sakthivel, did you send
Yes,
a
ma'am.
sputum gram stain and culture for this patient?
No, ma'am. When the time he presented, he doesn't have any cough or expectoration, ma'am. So we didn't send, ma'am. Blood
Okay,
culture
what
we
about
sent, it
blood
was sterile, ma'am.
culture?
It's sterile, ma'am.
Okay. And did this patient have a history of preceding influenza-like symptoms before coming to you?
No, ma'am.
Coryza?
No cough, cold,
Starting
running
before
nose.
this?
No, ma'am.
No.
No, ma'am.
Okay, because that is something we commonly see patients developing Staph aureus following an influenza infection.
Yes.
It's unlikely that that empyema will resolve on its own without some form of drainage. It's likely to get organized, and it may be, I don't think it's going to resolve without actually doing a drainage procedure.
Yes, ma'am. We multiple time insisted for the patient, ma'am, but patient was not willing. Initially, one time we tried it. He was very morbidly obese, but second time he not allowing us to put the tube, ma'am. So only we continue the IV antibiotics, ma'am.
Okay, because in such a situation, then you may want to consider giving a longer course of antibiotics. Maybe
Yes.
something like linezolid, which has good pulmonary penetration, you'd have to consider. Okay, anybody has anything to add? Any comments? Okay, so shall we just give all the six speakers a round of applause? I think we had some good presentations, and I think the mm, prize will go jointly to Tangamani and Ebetcha. Okay, I think we'll close here. Just a reminder to all those presenting, please make your presentations clinical. Okay, come to a clinical diagnosis, clinical syndromic diagnosis, and then work from there with the rest of your discussion. Thank you. See you in next week. Yeah.
Yes.